Are you like most professionals who haven't received training to meet the mental health needs of older adults? Well, this podcast is for you. Welcome to the Psychology of Aging podcast. I'm Dr. Regina Kepp. I'm a geropsychologist and founder of the Center for Mental Health and Aging. I created this podcast to give you tools and insights to meet the mental health needs of older adults. This is after 20 years of working with older adults in some of the largest healthcare systems in the United States. Each week, I share evidence-based tools that you can use with your clients starting today. And if you find the resources here helpful, check out our online continuing education courses at mentalhealthandaging.com. All right, let's jump into today's episode. Diabetes affects more than 34 million people in the United States, with another 87 million at significant risk for type 2 diabetes. With the prevalence of diabetes significantly increasing as we age, with close to 30% of 65 and older Americans living with diabetes, it's critical that mental health providers have the tools they need, that means you, to navigate assessment, diagnosis, and treatment. Depression is 2 times more likely in people living with diabetes than the general population. So in this podcast today, I interview Dr. Mary DeGroot. She's going to tell us all about depression and diabetes, what you need to know, and how you can help. Let me tell you about Dr. Mary DeGroot. She is an associate professor of medicine and acting director of the Diabetes Translational Research Center at Indiana University. She received her Master of Education degree from Harvard University Graduate School of Education and her doctorate in clinical psychology from the University of Rhode Island. Dr. DeGroot is a clinical health psychologist who has contributed to more than 100 articles and presentations on the psychosocial aspects of type 1 and type 2 diabetes, and her work has been published in the top journals of her field, including the American Psychologist and Diabetes Care. Dr. DeGroot's service to the field of diabetes and psychology is extensive. She was the past president of the Behavioral Diabetes Research Group Exchange, that's also known as BRIDGE, and that is the premier behavioral diabetes organization. From 2017 to 2021, Dr. DeGroot served on the National Board of Directors of the American Diabetes Association. In 2020, she served as the president of Healthcare and Education for the American Diabetes Association, and she currently serves on the Research Policy Committee of, you guessed it, the American Diabetes Association. Without further ado, let's jump into the interview and get all we can. Let's squeeze all of Dr. DeGroot's wisdom out so that we can help people living with depression and diabetes. All right, let's jump into the interview. Mary DeGroot, thank you so much for contributing your time and sharing your time with us today. This is a really important topic because so many lives are impacted by diabetes and depression. And so you're going to help us understand the link and what we as mental health and senior care professionals can do to help people living with depression and diabetes. So thank you so much for being here.
Oh, thank you, Regina, for the opportunity to join you in the podcast series and for the opportunity to talk with all of the listeners about this important topic. So it's my pleasure to join you.
How did you get interested in diabetes in general?
That was many years ago. I completed my master's degree at Harvard Graduate School of Education and was looking to pursue doctoral work in clinical psychology, but realized that I needed some research experience to be competitive. Clinical psychology programs have always been competitive, and at that time in the late 80s, early 1990s, it was 4 to 5 times more difficult to get into clinical psychology programs than it was medical school at that time, believe it or not. And so serendipity intervened, and I started working with Dr. Alan Jacobson, who at that time was the director of the mental health unit at the Joslin Diabetes Center in Boston. And I found my tribe. And thoroughly enjoyed working with him and being mentored by him, working with the incomparable Dr. Barbara Anderson, and Dr. Bill Polanski, all of whom were at the Joslin Diabetes Center at that time. And that really started my interest and love of this area, and my deep appreciation for everyone who lives with diabetes, and a desire to do whatever I could to help make that journey a little easier for people as they move through it over the course of their lives.
Wonderful. So it was a field that found you, or you kind of your lives intersected.
It was. I looked around and so admired the people that I was surrounded by, all of whom were incredible leaders in the field, and was learning so much from them. And then the very first study that I worked with Dr. Jacobson on as the research assistant was a study of the prevalence of diabetes and depression. And then I started in the context of our interview protocol for that study, started listening to the stories of our over 200 participants in that study, and hearing about their lives and journey, as well as some of their burdens with diabetes and depression. And I was hooked, just very interested and very connected to all of that.
Oh, just to help us get a feel for a life living with diabetes and depression, what were some of the challenges that those folks were living with?
Well, we have come to, since the early 1990s, late 80s, 1990s, we've come to understand a great deal about depression and diabetes. And I'm mindful that our podcast audience is a mix of both health professionals and people in the community. So I might want to back up a bit here and share some kind of background about both diabetes and depression, if that's okay with you.
Great.
So just to give ourselves some context, so we know that diabetes is in high abundance, not only in the U.S., but in the world. In the U.S., it affects more than 34.1 million people, with another 87 million people at risk for type 2 diabetes. The vast majority of people with diabetes have type 2 diabetes, and that's a combination of changes in metabolism as well as insulin insufficiency. Type 1 diabetes, on the other hand, is an autoimmune disorder for reasons that we still don't completely understand. The immune system turns on and targets the insulin-producing cells in the pancreas called the beta cells. They're located in a structure called the islets of Langerhans, which sounds like a Swedish vacation spot, but actually is a microstructure that has very small accommodations. For reasons, again, is that we don't completely understand, the autoimmune system attacks those cells so that people are not able to produce insulin inside their bodies any longer when they have type 1 diabetes. Type 1 diabetes tends to onset in childhood or early adulthood, and for some folks, that will onset in their 30s or 40s. Type 2 diabetes, we have typically thought of as an older adult medical condition, and while that is true, we have also been learning that type 2 diabetes, because it coexists with overweight and obesity in 90% of people who have it, can also affect children and adolescents. So we're increasingly thinking about both type 1 diabetes, the autoimmune disease, and type 2 diabetes, this metabolic dysregulation, as being conditions over the course of the lifetime. And typically when people are diagnosed with diabetes, they continue to carry that diagnosis over the course of their lives. We know that not only is diabetes plentiful, but the prevalence significantly increases over the course of aging. So the percentage of Americans 65 and older remains high, at nearly 30%. So 1 in 3 adults age 65 or older, or 15.9 million seniors, can be diagnosed or undiagnosed. And there's an average of 1.4 million new cases of diabetes every year. So this is a highly relevant condition for older adults. It is not a failure. I'm always quick to add whenever I meet new patients or talk with anyone, that we've typically thought of diabetes as a failure of moral character. That's sometimes how that's portrayed, or that's the messages that we've received. But that's not the case. It is a failure of your body being able to produce the insulin that it needs. There is a strong genetic component. There's also a strong environmental component to type 2 diabetes. And so, however we get there, excuse me, we get there honestly. And so it's really important that we don't engage in that kind of self-blame cycle, because it's unwarranted. And that's not how diabetes works. And it gets in the way of self-care. Diabetes also has a significant financial burden. So going as far back now as 2017, we know that diabetes costs upwards in excess of $327 billion, billion with a B, each year. And that's both direct medical costs as well as indirect costs for lost productivity and other kinds of ways that health intersects and interferes with our ability to do what we'd like to do, whether that's socially or financially or in terms of our various roles. We also know that diabetes can represent a significant burden to patients and families. We hope that it doesn't, but for some folks, it most certainly does. We ask people to do a great deal to care for their diabetes. It can be a complex set of recommendations for people to follow. We know that there are multiple time and resource demands, and that can be time spent lining up medications, that can be money spent paying copays for medications, that can be quality time on hold with insurance companies, of moving paperwork back and forth for approval. And all of that can contribute to decreased quality of life, as well as some of the physical impacts of diabetes, both short-term, low blood sugars or high blood sugars, hypoglycemia or hyperglycemia, as well as the risk or the development of diabetes long-term complications, which includes eye disease, kidney disease, heart disease, and so forth. So there are many components. Diabetes is complex. There's multiple facets to it. And so I like to really kind of put that all into context when we're thinking about diabetes and depression, because for some folks may have heard me say that, diabetes is hard enough. When we add depression on top of that, that makes it that much more difficult. And so just to kind of really set the stage there.
And among people living with diabetes, what percentage would you say are type 1 versus type 2?
Yeah, about 5% of people with diabetes have type 1 diabetes, so it is much less prevalent. And about 95% of people with diabetes have type 2 diabetes, that metabolic dysregulation.
I think it would be so helpful to hear a bit of your perspective on, you mentioned just a minute ago, when we start to shame ourselves or others. I hear a lot of other shaming around diabetes as well. It's not just self criticism, but other criticism, like, well, if they had just eaten better, they had just taken, there's a lot of other shaming. And you're saying, and of course we all know this, that's not helpful. And that actually, it's not only not helpful, it interferes with how we take care of ourselves. And so can you share a little bit about, just before we move to the next step, I do think it would be helpful just to hear your thinking about the link between what self-criticism and other criticism does to our own ability and willingness to take care of ourselves and even make any behavior changes, integrate any recommendations for care.
Absolutely. Absolutely. So we have a language that we've developed around diabetes, and that's, all of us who are connected to anyone who has diabetes. And so I affectionately refer to that sometimes as diabetes land. So all of us connected to diabetes in one way or another. And unfortunately, some of our old ways of thinking about diabetes involved themes of failure and themes of self-blame, as you were saying, and both of those themes contribute to what we call diabetes distress or diabetes burnout. Sometimes those terms are used separately. Sometimes they're used interchangeably. I'm going to use them here interchangeably. The basic idea is that when we have internalized or we have others, sometimes Dr. Bill Polanski referred to caring others who misstep, who engage in miscarried helping as the diabetes police. Sometimes when we have that happen and we receive these kinds of messages, we internalize them. And when we internalize them, then we engage in, or those thoughts and feelings get activated when we hear them from the outside about those themes of blame or shame. Combined with that is an extensive set of recommendations that we give people. Sometimes I fondly refer to those as the shoulds of diabetes. The recommendations that come from the American Diabetes Association, for example, and the medical standards of care that are published every January that guide the medical treatment of diabetes for all healthcare providers, are all based on very rigorous evidence. So these come from a good place. They come from strong evidence. But the way that we translate those frequently turns into should statements. Now, some should statements are good should statements, right? We learn those values in our families or through our faith traditions. But when it comes to medical self-care, right, and diabetes self-care, shoulds can convert choices into obligations. And when we've made that transition in our mind's eye, we don't tend to want to do things that we're obligated to do. And that will raise the specter of what's called in motivational interviewing the righting reflex, that tendency for us to say no and to push back when we're feeling pushed outside of our comfort zone. And so that complicates the process of self-care. If I'm feeling pushed, if I'm feeling deprived, if I'm feeling that I can never have the foods I love again, or that the things that I've done to take care of myself are suddenly having the opposite effect, then I'm going to resist, because that's a natural human impulse, and that's really how the brain is wired. So it becomes a complicated landscape. So how we understand our relationship to diabetes is really important. And the more we can steer away from should statements, the more we can engage in making choices, informed choices, and hopefully healthy choices. And the more that we can steer away from this term control that we love to use in diabetes land, which is a bit of a misnomer, because we can't think our way to a good blood sugar, right? We can guide blood sugars, we can influence them, we can manage them, but we can't just think and concentrate very hard and say, I want a blood sugar of 112 right now. Literally, there's no wiring for that. From the brain to the complexities of the metabolic system of our whole body. So instead, we need to really be thinking about our appropriate stance and role, which is to manage and to influence our body and how it's functioning. And when we do that, we open up more possibilities, both in terms of our thinking and then in terms of our self-care. So it's a rich topic, and I could certainly talk a lot more about that. But I'm so glad that you asked the question.
And I'm sure one that does intersect with depression, because of there's a stigma now if there are diabetes police, or we're not doing it right, or we haven't, or we're experiencing self-shame or self-criticism and other shame and other criticism and policing and shoulding. It's I'm sure all of that has an influence on depression as well.
Absolutely. It can help to reinforce depression. It can help to inform the core beliefs that are the engine of depression underneath, if we think from a cognitive behavioral therapy perspective. Absolutely. Yep.
Mm-hmm. I see that a lot with caregivers. So I'm so glad you're bringing this up. The family member who's really concerned about their loved one and is acting from a place of maybe even a sense of feeling out of control and wanting to have some order in the chaos of a medical system and a medical a life living with a medical condition. And so sometimes there's some overbearing or missteps, like you said, that I think is so helpful to just as you did, bring to the table. It's a common thing, and we can be mindful and shift it.
Right. And one of the antidotes to that, the diabetes police role is really unfair to both parties, right? So it provides miscarried helping to the person with diabetes. It also can be very stressful for the loving, caring person who wants the best for the person with diabetes, and who may be a spouse or maybe an adult child who's very invested in the outcome of the person with diabetes, right? They have a life together, and they are connected to each other. And so the antidote to the diabetes police dance, if you will, kind of how people interact around this, is to empower the person with diabetes, right? So one of the best things that those of us without diabetes can do for people with diabetes is to ask questions. What can I do to be helpful to you? We need to first to ask, and then we need the companion to that is to listen, right? And to really listen to the answer. It's really important that we ask that question, because that helps to cue the person with diabetes to give it some thought. What would constitute truly helpful assistance? That might be tangible, that might be intangible, that might be a listening ear, that might be, hey, let's proceed, all things normal, I got this. And it's also important for us to know kind of where our lane is if we're a support person. That can be tricky, right? This sounds simple, but as with all things, it's easier said than done. And it can be an ongoing conversation. It may not be a conversation that you have every week, but it's one that you can continue to check in with the person with diabetes, because things change, medications change, regimens change, health condition changes, and those needs will change over time. If you're an adult child working with an older adult parent, right? So empowering your parent of what do you need, and how can I be truly helpful to you? That might be information gathering, that might be attending a doctor's visit or not. It might be tangible support, it might be more emotional support. But really thinking about and having an open conversation about what constitutes help in the eye of the beholder there really matters. And then that way help is a lot like art. It's all in the eye of the beholder.
Dr. de Groot, I just have to highlight the quote, ask, and the companion to asking is to listen. Yeah, that's so beautiful. A lesson that we could all take to heart.
Absolutely, right? We can practice it every day. Yeah.
Do you think this is a good time to move to depression?
Sure. Yeah. Let me tell you a little bit about depression. So, for the healthcare providers who are listening to our podcast, they'll be familiar with these criteria, but I like to share these for people who may not be familiar with what our formal definitions of depression are. Because, again, as with diabetes, we have lots of popular ideas about depression. And so, just to kind of ground ourselves in our conversation here. So we think about depression, and here I'm referring to major depression, or sometimes referred to as clinical depression, as a period. It's an episode. It's a period of time lasting at least 2 weeks or longer, in which people feel depressed or down most of the day, nearly every day, and or a lack of pleasure in things that they would ordinarily enjoy. So for some people, they may not necessarily get the feeling of being sad or down or having the blues, but the colors run out of life, and they may have a distinct lack of pleasure or enjoyment in things that they would ordinarily enjoy. And so either of those counts as core criteria. And then in combination with one or both of those core criteria, people may have changes to their sleep pattern. They may be getting too little sleep. They may be sleeping much more than they normally would. They may not be feeling rested from the additional sleep that they're getting. They may have changes in appetite or weight, maybe a lack of appetite, or maybe an insatiable appetite that's uncharacteristic of their normal pattern. People may feel very lethargic, high levels of fatigue. They may have decreased ability to concentrate or to attend to everyday tasks, paying bills, following TV programs, things like that, that are beyond what their normal level of concentration is. For some people, they may end up feeling like they're moving through molasses, moving much more slowly, or feeling agitated and keyed up and pacing, just not being able to sit still comfortably. For some people, they will experience feelings of worthlessness or feeling much guiltier about things than they might otherwise feel if they weren't feeling depressed. And then last but not least, some people, fortunately a small proportion of people, may have thoughts of death. They may have thoughts that they may be better off dead, or they may be thinking about taking steps to end their life. And typically that has a lot to do with emotional pain. This is not just contemplating mortality, but it's really a way to try to end a longstanding emotional pain. So we think about those symptoms, or at least 5 of those constitute major depressive disorder. You can certainly have fewer than 5, and if it affects impairment, that counts too as clinical depression. And very important to be aware of those symptoms because they matter. Again, diabetes is hard enough. We add depression on top of that, it makes it that much more difficult. So one of the things we know is that depression is prevalent in people with diabetes. Depression is 2 times more likely in people with diabetes than we've observed in the general population. Diabetes is not the only chronic medical condition in which people may have elevated rates of depression. There are others as well, but 2 times more likely is still a great deal, and so we care a great deal about that. And 1 in 4 people with diabetes will have depression in their lifetime. We can think about this as different levels. So people with depressive symptoms, that's about 1 in 5. People with a depressive disorder where that really causes impairment in work or social functioning is about 1 in 8 people. And so that really matters. We also know that interestingly, rates of depression do not significantly differ by diabetes type. So people with type 1 diabetes and type 2 diabetes seem to have similar rates of elevated depressive symptoms, anywhere from 21 to 27%. We know that women are 60% more likely to experience depression when they have diabetes than their male counterparts. Which is consistent with what we know in the general population, that unfortunately as women, we're more likely to experience depression than men. And we also know that how we assess depression makes a difference. So for healthcare providers listening to this podcast, we know that when we get more specific through diagnostic interviewing, we can be more specific about which symptoms go with a medical condition and which ones can be attributed to depression, as opposed to screening questionnaires. But that's not to say that screening questionnaires aren't helpful, because they are, and I'll talk more about that in a bit. Other factors just to be aware of in terms of prevalence, in addition to differential rates by gender, so women having 60% increased risk of depression with diabetes, we have observed over time that there are comparable rates of depression across ethnic groups. And that's really interesting because we know that diabetes is not equally distributed across communities. So we know that socioeconomic status, so poverty, lack of access to resources, lack of healthy environments, communities of color, are all at greater risk for, particularly for type 2 diabetes than more affluent or predominantly white environments. But the rates of depression seem to be comparable. So that suggests that we've got a biological component there that's evening out the playing field in a way that still merits more investigation. We also know that in the last 2 years, we're now at the point of the 2-year anniversary of the pandemic in the US, that COVID-19 has not helped with our rates of depression prevalence for people with diabetes or people without diabetes. So work that me and my team have done over the last 18 months, the Indiana University National COVID-19 Study, we observed increased rates of depressive symptoms in both people with and without diabetes. So COVID-19 has affected all of us in terms of mood. We've also seen elevated and consistent rates of diabetes distress in people with type 1 diabetes as well as people with type 2 diabetes. And those rates of distress are at a moderate level, which is concerning. It has clinical implications for how people are caring for themselves. So with stressors, and we certainly have had plenty of stressors in our environment over the last 2 years, that just exacerbates these tendencies even more. Another interesting piece about the relationship of diabetes and depression is the directionality of diabetes and depression. And that is that we used to assume that diabetes was hard, and so that process of caring for oneself 24/7, 365 without getting a vacation would naturally prime people for developing depression. And we do know that having diabetes first does increase the risk of developing depression later on, anywhere from 38% to 60% of increasing the risk of having first diabetes and then depression. But we've also learned that people who have a lifetime history of depression have an increased risk of developing diabetes, type 2 diabetes later on. And that's after controlling for other common factors, obesity, gender, poverty, and other factors. So there's something very interesting about the physiology of diabetes and depression that seems to go hand in hand with one another. That makes mood history very relevant for patients with diabetes, to talk with our healthcare providers, and I'll say more about that at the end of our interview here. But if you have a history of depression, and you're newly diagnosed with diabetes, that's really important for your provider to know. It's good information that can be monitored over time. So that both conditions can be managed well, and that you as a patient or you as a family can get the support that you need to manage both of those conditions. So those are pieces. I would also add that we've been learning a lot about how depression behaves once it onsets for people with diabetes. So one of the questions has been, well, is it like everyone else in the general population, or are there special considerations for people with diabetes? Early on, we knew that when we looked at cross-sectional surveys, so we would ask people about their symptoms at one time point, and then maybe 6, 12, or 18 months later, we'd ask those same people about their symptoms again, that about 80% of people, anywhere between 77 and 80% of people, reported consistent reports of depressive symptoms. And so that gave us a clue that depression, once it developed, maybe it doesn't resolve easily for people with diabetes. Some of the work that I've had the privilege to do has looked at longitudinal surveys of people who are presenting for depression treatment. And this has been conducted in 2 different studies now, called Program Active 1 and Program Active 2, creatively enough. And these were all adults with type 2 diabetes whose average duration of diabetes was about 10 years. The 2 samples were very similar to each other, but separate and collected at separate times. And what we found in these samples, when we asked people about their lifetime history of depression, so this was retrospective, we asked them to think back about their history of depression, and we asked them to think about the onset and offset of depressive episodes as it related to other life events. What we found was that the average exposure to depression was not 8 to 12 weeks, as we have seen in the general population for an episode of depression, but that in fact depression lasted anywhere from 23 to 27 months. So this is an order of magnitude longer than we see in the general population. And that mean lifetime exposure to all forms of depression was nearly 5 years. So it suggests that when depression and diabetes go hand in hand, they tend to reinforce each other and that depression will not necessarily spontaneously remit or just go away on its own, but that in fact it has a lasting effect that requires more intervention than we might otherwise need if we didn't have diabetes as part of the mix. So we care about that a great deal, and I think that's all the more reason that this is an important topic, and I'm so glad we're talking about it. And then last but not least, I'll just add one other piece here, which is that we care not only about depression because depression is hard, but also it has impacts on diabetes. So we know that when depression and diabetes go hand in hand, it's harder to manage blood sugar levels. That's both behavioral and also appears to be physiologic. We know that depression and diabetes increases the risk of both short-term and long-term diabetes complications. And that's work that we observed back in the early 2000s and then has been repeated in some excellent work by Ari Nguyen and colleagues just in the last couple of years. We know that it's harder to manage diabetes when you're depressed. So all of the things that you're asked to do get that much more difficult. And so adherence to self-care gets decreased and medical costs go up. And that it would be great if those were medical costs associated with treatment of depression. But that tends not to be the case. And so it costs more than when we have both conditions as well. And then finally, if that weren't enough, we know that people don't function as well. So there's increased levels of functional disability for people with depression and diabetes together, and premature mortality from all causes. So this just gives us all the more reason that we really care about diabetes, we care about depression, and we care a lot about when those two are happening for a given patient or within a family.
Oh, that's such a helpful overview. I'm curious, what are the distinctions between you describe depression, clinical major depressive disorder, and you've also kind of mentioned in there diabetes distress and diabetes burnout. Can you share for us a bit about how you differentiate each of those?
Yeah, that's a great question. So we used to kind of mix them all up. And over the past 20 years, we've come to understand that they really are distinct phenomena. But they can coexist with one another, which makes it a little tricky. So depression is a function of mood, and it has impacts for diabetes. Diabetes distress is a function of living with diabetes. So rates of diabetes distress are actually much higher than even rates of depression. So anywhere to 42 to 45% of people will experience diabetes distress at some point in their journey with their diabetes. So that's almost half. It's very high. Diabetes distress is associated with the emotional burden of managing diabetes, and it's specific to the experience of living with diabetes. It can involve regimen burden, so feeling just burdened by the self-care expectations and recommendations. It can involve interpersonal relationships. It can involve feelings of powerlessness, and it can involve relationships with healthcare providers. So all of that is very consistent with diabetes. The underlying substrate that we're beginning to understand about diabetes distress is that it's about emotional regulation in the context of the stress of diabetes. So very specific and has a closer relationship to A1C than depression, which is not to say that the relationship to depression isn't important, because it is. But because diabetes distress is about diabetes, it has a closer relationship to A1C. So when diabetes distress goes up, A1C also tends to go up, which is why one of the reasons that we care a great deal about that too.
And burnout?
So we used to think about those as interchangeable, and many people still use those terms interchangeably. Sometimes I do too. But we're moving in a direction in the literature of understanding that we can have kind of the difference between emotions and behaviors. So diabetes distress is the emotional experience of diabetes. Diabetes burnout may be the behavioral manifestation of that. So the disengagement of managing diabetes self-care. So maybe missing medication doses, maybe not making the food choices that you would otherwise make, maybe missing physician appointments when out of shame or fear or a feeling disengaged from diabetes. So I think about the distinction between those two is one is emotional and one is more behavioral.
There are so many reasons to care about this. I know you mentioned just the long-term impact, the long-term relationship between diabetes and depression. So, the more than a year of living with depression, if you have diabetes, is the mean. Is that what you said? And 23 to 27 months or something. And then and I just think about the level of suffering, the prolonged level of suffering and what that does to a person and their sense of worth and a sense of purpose and meaning, and what that does to family and community. And I think there are so many physical, physiological, interpersonal, and just in terms of a peaceful human experience, just to alleviate the suffering. I had no idea. I work a lot with people who are medically vulnerable and many people who live with diabetes. And I had this is the first time that I'm learning about the long life of diabetes and depression together. And that's another reason to care about this. It's just that there's long suffering. And I know we're going to be shifting in a minute to what we can do about it. And so I'm just looking forward to learning more about how to be really helpful to help alleviate some of this suffering.
Absolutely. Right. Yeah. And one of the things that happens experientially for some people is that, it's not like flipping a switch, the experience of depression, right? So for some people, they'll describe their journey with depression in the context of their diabetes as they're just working harder and harder and harder but not having the same levels of accomplishments over time, whether that's personal or family or work role or social roles. And so it's kind of a grinding down sort of experience where it just gets harder and harder and harder. Which makes it tricky to recognize because it's not like the flip of a switch. And sometimes the attribution is, well, it is my job, or, oh, it is this, or, oh, it is that, or, oh, it's a relationship phenomenon, or, and so it can be harder to see that something's happening inside of me that's making this more difficult. Just not to blame people for depression because it's not about that, but it can make it a little more difficult to recognize. But early detection is really the key. So if we can prevent the brain from long-term exposure of depression, we can reduce the risk of future depressive episodes. And that's another piece. What we found in both of our studies is that people who had one depressive episode, like the general population, people with diabetes who had one depressive episode had an increased risk of developing a second episode. People who had two episodes had an increased risk of developing a third. And it appears that those episodes get longer each time they happen. So all the more reason we want to reduce the exposure to the brain of depression and nip it in the bud as soon as we can so that people don't have that long-term process of suffering. Because they don't have to feel that way.
Yeah, and treatments are effective.
They are. Yes, that's the great news about depression and diabetes. So when I got into this field very early on, I wanted to, I wanted to learn about it and kind of what is this like, but then also what do we do about it? And so the really good news, here's a spoiler alert, is that we have tools for this and people don't have to suffer. So.
And to your point too about early detection, just to put a plug in around the older adults, is older adults are commonly not detected early when they're experiencing depression. And that's because there is a myth or a misbelief that it's normal to be depressed as we age, and that is not true. And so the earlier we can detect depression in the context of diabetes. And since you shared with us earlier the prevalence of diabetes among older adults, it's also important to remember early detection is key for older adults as well. And
absolutely.
And depression is not normal with aging, and treatments are highly, highly effective.
Exactly, right. And in the modern era, I think we're on our way to challenging those old beliefs about aging must mean disability and depression and disease. And in fact, we now know that successful aging is not only possible, but is much preferred
and more probable.
And more probable and more accessible than ever. But what that means is that it means addressing changes when they occur. And the earlier we can detect those changes and the earlier we can address them, that means that we're going to increase the likelihood of successful aging. That's a conversation I have with many of my patients, is to kind of offer the question of, what does successful aging mean for you? So anyone who's listening to this, I offer you that same question, and to be thinking about your role models for successful aging. What does that look like? What does that feel like? And what are the sources of fulfillment and purpose and relevance that your role models have and that you would like to have for yourself, whether you're in midlife, whether you're in your 20s or 30s, or you're closer to the other end of the spectrum of age. So yeah, really wonderful point.
Okay, well, let's fill them in. Let's talk about treatment.
Okay, yes. So first step before we even get to treatment is screening. So, and that is both self-screening if you're a person with diabetes, and also for healthcare professionals for formal screening, whether that is a conversation with your patient or if that's using screening tools. So one of the things we know is that, to your point, Regina, that depression is consistently underdiagnosed and underreported, not only in older adults, but in the population more generally. We also know that as healthcare providers, if we ask questions and we listen to the answers, our patients will share. It will break that old script of the medical script of the interactions we tend to have when we're talking with our healthcare providers. We also need to recognize as healthcare providers that sharing mood information can make people feel vulnerable, and not everyone is comfortable sharing that information, particularly in communities where there has been a history of violation or oppression or not being taken seriously or being over-pathologized. So many ethnic communities are hesitant to talk about some of these more vulnerable experiences, and which means that we need to take the extra efforts to help people feel safe in their care, safe in their interpersonal relationship with us as healthcare providers, and to be sensitive with how we have those conversations, because it's all about safety first and in everything that we do. We also know that as healthcare providers, sometimes we worry about asking screening questions. Even though we know better, we may still have that old feeling of, well, if I ask about it, will I be inducing it? Will I be inducing depression? And the answer, good news, the answer is no. And then the next question is, well, will my patient reject me or reject the idea of treatment? And what we know from the literature is that patient attitudes are actually quite positive if people get a treatment that's appropriate for what they need and they see results. So we can have some good confidence that we can have these conversations with our patients, and that gets us on the right road to not only reducing suffering for our patients, but also making our work as healthcare providers easier, because we're not just working against whatever the conditions are associated with a person's state of diabetes, but we're also having to kind of work against depression and how that's not supporting that person with diabetes. So ways we can screen. We can ask simple questions. How's your mood been in the past 2 weeks? Have you felt depressed or down most of the day, nearly every day in the past 2 weeks? Have you had a loss of interest in things that you would otherwise enjoy? Simple questions. They don't need to take a lot of time. but they can get you really good information. Are we on the map of depression, or is this something that's not even relevant to your patient? Asking really opens up that door. It also makes it a legitimate topic for your patients so that it gives them permission and encourages them to share that information with you at subsequent visits if that becomes relevant. We have a variety of screening questionnaires that can be built into the check-in process. So my patients will complete a Beck depression inventory when they check in for their appointment while they're waiting for me to come see them. Many electronic health records have the PHQ-9, the patient health questionnaire, which is a depression screener that is built into the healthcare system already. Great information if that's already collected. The geriatric depression scale is particularly focused for older adults and helps to, and the questions are framed in such a way so that you're not capturing artifacts of aging, physical changes associated with aging, and misattributing those to mood. So we just want the right tool for the right population. What's really important about using screening questionnaires is that we look at the answers and that we do that in real time. So if we're asking people about depressive symptoms, we're asking them about suicidal ideation and intent or plan, that we've reviewed those items so that we can take the necessary steps to ask follow-up questions should those be relevant for your patient at that time. And then, of course, documenting how we've addressed those concerns if they have been evident either in our interview or in our questionnaire. So first step is screening. Second step is treatment. So the really good news about depression is that we have multiple tools now that we can use to treat depression. We have a wide variety of antidepressant medications that are available for the general population, and a subset of those have been tested for their effectiveness for people with diabetes and depression comorbidly. We also know that psychotherapy, counseling, is an effective tool, and I'll talk a little bit about that. And then when we combine counseling and exercise, it turns out that that's highly effective too for people with diabetes and depression. So in terms of medication treatments for depression, studies have tested both the tricyclic antidepressant medications and the selective serotonin reuptake inhibitors, or SSRIs, and then their cousins, the SNRIs, and have found that both of those families of antidepressant medications are effective in treating depression in people, in samples of people with diabetes. So good news that the same treatment recommendations that we would use for someone without diabetes can also be used with diabetes. With diabetes and advanced complications comes pain presentations, neuropathic pain, which is a long-term complication of diabetes. And so some medications may be used for more than one purpose. So Regina, you and I were talking before the interview about tricyclic antidepressants. There's been testing for people with diabetes of nortriptyline at the 25 to 50 milligram per day level that has been found to be effective in treating depression. It also can be effective for use in treating neuropathic pain, so it can be kind of a 2-for-1. It's generic so that it's low cost, and that makes it accessible for many people. But there also are some considerations you were mentioning about for older adults. And if you'd like to share those, that would be great for people to know.
Yeah, so there has been also research that their TCAs are contraindicated in older adults due to postural hypotension, which can contribute to falls and fractures, cardiac conduction abnormalities, and anticholinergic effects. So the moral of this story, I also have had older adults who I do work with who are prescribed TCAs for neuropathic pain or other types of pain related to spinal cord injuries. And so I would say the moral of the story is to really consult with your physician about what medication is right for you, given your the interactions with other medications, as well as any considerations with age or cognitive function.
Absolutely. Yes, I completely agree. Right. While the really good news is that we have many different options for treating depression now in ways that we didn't have even 30 years ago. And so, and we also know that because the brain is highly specialized, one size does not fit all, and even the first medication may not be the right medication for our patients. And so setting the stage for patients so that they have an understanding that this is a process of figuring out the right fit, and also then tailoring those medications for the whole medical picture is critical, a very important part of effective treatment. Absolutely, yeah. Moving on then from medications to psychotherapy. So we have a large body of literature in the general population that counseling or one-on-one or even group counseling can be effective in treating depression. And we found this to be also true for people with diabetes. So cognitive behavioral therapy is our go-to these days. And for those who may not be familiar with that term, that is understanding the thoughts, feelings, and behaviors that interact with one another to that we use, and habits of thinking that we use all day long. When we are depressed, some of those habits of thinking are shaped in particular ways and that help to keep us in that rut of depression. I think about it like a path through the woods, and the longer we walk that same path, the deeper the rut is in along that trail. And so in cognitive behavioral therapy, people get to understand how their thoughts and feelings and behaviors interact with one another, how they're related and impacted by your physical body, and as well as the environment. And then looking for patterns that don't serve us very well, that may not be realistic appraisals of our current situation as it is today. So we know that cognitive behavioral therapy is effective in treating depression. Multiple studies have evaluated that in type 2 diabetes for adults. We also know that problem-solving therapy is a variation of cognitive behavioral therapy. It's directed at let's identify some problems and let's think of strategies to resolve those. And we know that there are many ways to obtain counseling. So that can be individual psychotherapy. We used to think about that as an in-person only model, but now we know that virtual care is abundant and can be very effective for people and can actually overcome some of the access issues that people used to have. We know that collaborative care or multidisciplinary team care can be highly effective in identifying people who are struggling with depression and diabetes, and using a multidisciplinary team approach with case managers, which are typically nurses. The role of behavioral health and psychiatry can take a team approach to supporting people and treating depression effectively and efficiently. And then there are web-based approaches that predated our virtual health and telehealth initiatives, and that are also effective. Beating the Blues is one of those, as well as other approaches that have been developed in other parts of the world. So we know that when we look at these approaches, that they have not only an important effect on depression, but they also have the potential to improve A1C. So I just want to highlight here, doing kind of a shameless self-promotion for my own intervention, a set of interventions actually, called Program Active. Active is an acronym that stands for Adults Coming Together to Increase Vital Exercise, ACTIVE. We've conducted 2 studies now with the Program Active approach, which has 2 parts. One is a counseling approach that uses 10 sessions of cognitive behavioral therapy, and the other is a community-based exercise approach. And what we found when we tested these head-to-head, CBT alone versus exercise versus combination of the 2, delivered concurrently over a 12-week period, versus people who received only assessment, usual care, We found that people who received any of those active interventions, counseling, exercise alone, or the combination, had significant improvements in depression. So we were delighted to see that there's different ways you can get to the same place, which is feeling better. Not only did that improve depression, but it also improved other outcomes as well. So quality of life, self-efficacy, as well as some improvements in diabetes distress, even though that was not the primary target. We've also learned that when we combine counseling and the exercise or the exercise alone, we can also improve A1C. And not only did we observe that to be an improvement after the end of intervention, but we saw sustained effects of that 6 and 12 months later, which was actually kind of surprising for us, actually, because we weren't sure that we were going to have that much of a lasting effect. So it's really good news because it means that in terms of exercise, if people engage in about 150 minutes of aerobic or strengthening exercise per week, they do that safely. They do that in conjunction with what their body will let them do, and do it with a trainer or someone who can help guide what safe exercise looks like for your body at any given time. That not only helps with diabetes self-management, but also has an impact on mood. It affects the whole brain and gives us some real benefits. And the best part is that it's cost effective. And so work that we've done with colleagues at the University of Michigan helped us to be able to evaluate whether this was really a cost-saving or cost-effective approach. And it turned out that it is. So it has good effects, it can last, and it's worth it from a cost perspective. So.
And to your point about being good for the whole brain. So not only is it reducing depressive symptoms and depression altogether, it actually, those are the recommendations also of the Global Council on Brain Health for preventing or reducing risk for dementia disorders.
Exactly. Right. So that's, one of the things that we've been learning is how important physical activity is, not only for good blood circulation, but for brain activity more generally, and helps us to get to that goal of successful aging.
That's right.
At all points in the lifespan. Absolutely.
Before we move forward too, one of the things I wanted to go back to the screening questionnaires or screening tools that you mentioned. PHQ-9, just for folks listening, has also been normed with older adults. And the geriatric depression scale, which I really like if my patient has a dementia disorder or a cognitive impairment that might be interfering with their ability to answer a Likert model. Mm-hmm. And so I'm thinking of, in particular, in my mind, of a patient I've worked with post-stroke from diabetes. And when I would work with him, we would use the GDS, the geriatric depression scale, because it's a binary tool. So it's yes or no rather than a Likert model. And it was really helpful for folks with cognitive disorders when a PHQ-9 would be overwhelming or challenging to navigate.
Right. Yes. I think that's a really nice point. For those of us who are research oriented or who have just spent a lot of time in school, we tend to kind of take it for granted that using forms like questionnaires is something familiar. And for some of us it is, but for many people it's not, and it can be a little overwhelming. And if people are having mild cognitive impairments for any reason, it can be even more overwhelming. So yeah, it's a lovely point. Yeah.
Any statistically significant difference between exercise versus counseling, or are they about the same?
In terms of depression outcomes, they were comparable. Which we were really pleased to see, because different people want different kinds of tools. So in our study, we randomly assigned people to different conditions, but sometimes, as happens with research that's structured in that way, it's somewhat artificial, because we need to rigorously test our tools. And that's the point of the research. But in real life, people choose the tools that they want to pursue, right? And so I was pleased to see that when people were randomly assigned to these arms, that for depression outcomes, that counseling was just as good as the exercise and just as good as the combination. So people who prefer exercise and that feels like a better fit for them, perhaps they have access to programs like Silver Sneakers or other kinds of programs, that may be the natural route to go, and that will be very helpful. For other folks, it's about relationships, and it's about conversation, and it's about sharing and setting goals and then working toward those goals. And then so the counseling route can be helpful for them. And for some people, the kind of getting that additional combination is highly useful. When it came to A1C, we saw more of an effect for people who received either the combination or the exercise alone. And that made a lot of sense to us because A1C is a measure of average glucose over the life of a red blood cell, 2 to 3 months. It's a physiologic measure. It's a measure of how the body is doing. And we would expect that exercise would have a more direct effect on A1C than talk therapy. So the exercise piece does help to contribute to A1C. And that's great news too. So we're just delighted.
The story here started in a pretty dark place, deep in that forest, and that the trees are comprised of diabetes and physiological changes and depression and family concern and distress, burnout, right? And what, the arc of our meeting today has led us to a path forward that we can clear the forest. We can help people live a more fulfilling, vibrant, free of suffering or less suffering life with some pretty applicable treatments. 10 sessions of CBT, or was it 8 sessions of 10?
10.
And yeah. Exercise. And so, this is really a story of hope and opportunity.
It is. I love how you framed that, Regina. And I see it that way too. And that's one of the reasons that I find this work to be so gratifying is that we have good news about depression and diabetes. We also have good news about diabetes prevention too. So we can prevent diabetes where we can, and if we can't, that we don't have to have prolonged periods of suffering. There are some takeaways that I'd love to share with your audience here about diabetes and depression. And I hope that there's little nuggets in here for whatever your background is, that there's something that you've been able to get out of our conversation today. For providers, some of the implications of this body of literature that has grown over the past really 50 years, but certainly more intensively in the past 25 to 30 years. It's important to know that rates of depression do exceed, for people with diabetes, exceed those that we see in the general population. And that's true for adults with type 1 and type 2 diabetes. Also important to keep in mind that depression is recurrent. So if you have one depressive episode, there is an increased risk of developing subsequent depressive episodes. And depression appears to be persistent. And that means greater depression exposure increases the risk of greater glycemic dysregulation. So we care about that for lots of reasons that we've talked about. Early detection of depression, however, creates a pathway for care that has the potential to decrease exposure to depression and its consequences. So the earlier we can detect it, the better off our patients can be because we can connect them to treatment. And we have multiple treatment modalities available, whether that's virtual care, whether that's in-person care, whether that's exercise, talk therapy, or medications, or a combination. We shouldn't be shy about thinking about combinations if depression is particularly tenacious. And then I also want to point out to folks about a new resource that's became available just last year, that's available for free on the American Diabetes Association website, diabetes.org, that's called Diabetes and Emotional Health, a practical guide for health professionals supporting adults with type 1 and type 2 diabetes. This is a wonderful resource guide that originated in Australia, actually. Doctors Jane Spate and Crystal Hendricks put together their resource guide that was specific to resources available in Australia. It was then culturally translated for the United Kingdom, and then has most recently been culturally translated for here in the U.S. It has screening measures in it. It has information tips. tip sheets that you can share with your patients, and is just good, solid information, not only about depression and diabetes, but also diabetes distress, anxiety, and some other common psychological conditions. So a really great resource available for free. Download your copy today because it's there for you. And then for people with diabetes, for anyone who may be listening or a family member who may be listening on behalf of a loved one with diabetes, a couple of key takeaways. First is depression can be treated. So it does happen, and it can be treated. So that's the really good news. And also that we've had a lot of environmental invitations for depression and depressive symptoms since the onset of the COVID-19 pandemic. What we see now, my practice is overflowing with referrals, as it is the case for many mental health providers, because many people have been so deeply affected by our world events. Just know that that there are many ways to get to feeling better. And a great way to start is to share any changes that you are experiencing in your mood symptoms with your providers. Even if your provider doesn't think to ask, which we hope they will, but even if they don't ask, this is important information that you can offer to them. Really helpful for them to know about how the big picture is for you, and also for the two of you to have an empowered conversation about what your options are and what makes sense in the context of your larger health. We can all go to the internet now and in this age of information and look up generic recommendations, but there's nothing like having a healthcare provider who knows you to help tailor that information and filter that for what's really relevant for your particular presentation and set of circumstances inside your body and outside as well. And there are many choices right now and many roads to health. And then last but not least, I would invite people with diabetes to continue to share updates about your health and about your mood with your healthcare providers over time, beyond that initial conversation. Sometimes it can be hard to connect with care. We know that. This is structural. It's not your fault. But having the repeated conversation with your healthcare provider helps them to know where you're at and gives you a resource to brainstorm about what other options might be available. If the first option doesn't work, it's okay. We have many to choose from. So just kind of keeping that conversation going, I think, is a really important piece.
Well, that's such a helpful tip, because I hear from a lot of my patients, well, I don't want to even talk to my psychiatrist about this medication not working because they're going to get sick of me, or they're tired of things not working for me. And you're so right, Mary, to really encourage continued dialogue and to not stop the conversation because an intervention is not effective for you.
Right. There's no shame in that. Everybody's body is different. Side effects are not universally acceptable for people. Some people don't have them at all. Other people may be like, no, this is not for me. But sharing that information is really helpful.
Yeah. Well, this is so helpful. I just really appreciate your wisdom here, the work that you do to, you're saying if counseling's not for you, exercise can be helpful. There are many roads to improving diabetes and depression simultaneously.
Exactly. Yes. Yeah.
Thank you so much. We'll link to the resources that you shared with us and in the show notes. Okay. That will be available for everyone. And then folks can get, register to get continuing education credits as well. All the information will be linked on the show notes page.
Great. Well, thank you so much, Regina, for this time together. And thanks to everyone for listening.
Thank you.
It's been a pleasure.
Calling all mental health providers. Have you been feeling ineffective, stuck, or unsure of how to best help your client with memory loss? Well, it's not your fault. Most therapists haven't had any training in addressing memory loss or cognitive changes in therapy. But I got something for you. In my free 10-minute video where I walk you through 5 steps for helping your clients presenting with memory loss, you'll learn the difference between memory loss and mental health concerns for older adults and how to help. Get this free training and a bonus workbook that you can start using in your clinic today. simply go to www.mentalhealthandaging.com/clarity to learn more. That's www.mentalhealthandaging.com/clarity, CLARITY.